Welcome to the 10th Annual Airway Research Article of the Year show with Dr. Calvin Brown.
Great. Thank you, Terry. And it's great to be here with everyone to recognize 4 great contributions to airway management research. The nominees for this award have been selected among the many outstanding research articles we discussed during the Quarterly Research Updates this past year. I will present the nominees briefly, and you all get to choose the winner. So it's pretty exciting. So let's get started with presenting our 4 nominees. Now, I'm not saying you have to agree with these, but I thought that these were worthy of consideration. So the reasons why these 4 papers, we're going to get back to in a second, were chosen were the following. The paper really had to have fairly clean methods. In other words, there didn't need to be, there shouldn't be a lot of controversy in the way the data are analyzed. It's great that there's a discrete take-home message. There's a little nugget of information that you can take home, remember, and use perhaps on your very next shift. Some things that are practice-changing or eye-opening, and hopefully always something that's widely applicable. So let's look at our 4 contenders. The first one was from this last research update in December, entitled Engagement of the Median Glossoepiglottic Fold in Laryngeal View During Emergency Department Intubation. This is by Brian Driver and the group out of Hennepin. The second, also from Annals of Emergency Medicine, is entitled Assessment of the Thyromental Height Test as an Effective Single Airway Evaluation Tool to Assess for Airway Difficulty. The third is the Association of Rocuronium Dosing and First Attempt Success in Emergency Department Intubations. And the last one is Peri-Intubation Cardiac Arrest in the Emergency Department, a National Emergency Airway Registry study, which was a paper in Resuscitation recently that looked at risk factors for peri-intubation arrest. Okay, so let's start with the first paper. We just reviewed this during the last research update, and it's entitled Engagement of the Median Glossoepiglottic Fold and Laryngeal View During Emergency Department Intubations. So as you know, laryngoscopy with a Macintosh blade involves placement of the blade in the vallecula and engagement of the median glossoepiglottic fold, under which is the hyoepiglottic ligament, which is a structure which, when depressed by the Macintosh blade, elevates the epiglottis and exposes the glottic inlet. And how that impacts glottic exposure in emergency department patients has not really been looked at. So what Brian and his group did is they took video evidence of over 200 intubations and did a comparison of glottic exposure outcomes when it was clear by video evidence that the blade did or versus did not engage the hyoepiglottic ligament. You can see here in these 3 pictures, the black arrow is pointing at this median glossoepiglottic fold. You can see that the CMAC blade is starting to approach that fold. It slowly depresses it in the middle picture, and then when it's fully depressed, it lifts indirectly like a marionette string, lifts the epiglottis and exposes the glottic inlet. What they found is a significant increase in intubatable views when the midline vallecular fold was engaged, and that was 96% versus 87%, which is a 9% absolute difference of obtaining a 1 or 2A view on laryngoscopy with a CMAC. When you compared POGO scores, it showed a similar finding, which is that there was a higher percentage of glottic opening when the midline vallecular fold was engaged. And the take-home message here, and why this was a good paper in my mind, is number one, this is a basic technique in laryngoscopy. And when folks are intubating with a Macintosh blade and they're having trouble with glottic exposure, even though the epiglottis and the vallecula is fully visualized, it is a simple little maneuver sometimes that trips people up and keeps them from having a relatively easy airway from one that's actually quite complicated at that moment. So this is one that showed the importance of a simple basic technique and a dramatic improvement in glottic exposure, which has a direct impact on intubation success and patient safety. It was a neat little study. It involved video review with a very discrete take-home message and easily digestible data. So that's contender number one. Contender number two is entitled Peri-intubation Cardiac Arrest in the Emergency Department, a National Emergency Airway Registry Study. NEAR, for those of you who are new, is an observational registry of emergency department intubations, 25 centers. This version has over 19,000 intubations, and this was an assessment, a secondary assessment of these data, looking in particular at patients who suffered peri-intubation arrest, which was circulatory collapse within 15 minutes of receiving drugs and getting intubated in the emergency department. When you looked at peri-intubation arrest so two different cohorts, patients without peri-intubation arrest and patients with peri-intubation arrest, you can see that there was a higher percentage of patients who had hypotension and hypoxemia pre-intubation in the patients who ultimately arrested. You can see highlighted here in the red box. When you did multivariable logistic regression and came up with an adjusted odds of peri-intubation cardiac arrest, what we found is that there were essentially three things that predicted a patient was going to have or was at increased risk of having peri-intubation arrest around the time you intubate them. The first is whether or not they arrive in shock. Right? This seems to be a no-brainer, but the reason why this is important is because when you're about to intubate a patient who is hypotensive and in clinical shock, this is a red flag. This is a warning sign that unless the tube needs to go in immediately, this shock state needs to be addressed and resuscitated before you give the patient induction agents, which are going to cause vasoplegia and myocardial depression, and then also hook them up to positive pressure ventilation. Both of those things in someone who doesn't have treated shock gives you, at least in this analysis, an adjusted odds of being 6 times higher of suffering cardiac arrest compared to non-shock patients around emergency airway management. We found similar things with peri-intubation hypoxemia and the need for an emergent intubation. And what that line means is that the need for intubation was so instantaneous that the operators did not have time to address either shock or hypoxemia before the tube needed to go in. And you can see that the adjusted odds of having cardiac arrest ranged anywhere from 2 to 6, essentially, depending on what was going on. So this is pretty stark evidence that resuscitate before you intubate, unless the intubation can't wait, is a very important thing in airway management. And this needs to be thought about and addressed before drugs are pushed and a tube is placed. So I thought this was an important paper because looking at ED patients only, it was very, very clear the degree to which these factors play a role in cardiac arrest around airway management, and highlights how important it is to address these before airway management is undertaken. Okay, the third contender is assessment of the thyromental height test as an effective airway evaluation tool. And this was a great little paper. It was really more of a review than it was a research paper. But it was interesting because we have lots of bedside assessment tools and mnemonics to assess for airway difficulty. We have the Lemon Law, we have the Heaven Rule. There are a lot of these things out there. The problem with all of them is that there are multiple parts to them. There are multiple elements, and not all of them can be performed in an emergency department patient because some of them require there's a volitional component. So that begged the question, is there a single assessment you can do at the bedside that does not require head movement, does not require patient cooperation, that might give you similar awareness of airway difficulty without having to do these other more complicated mnemonics. And so the investigators decided, well, why don't we look at this, the thyromental height, which is the distance from the mentis of the mandible essentially to the top of the thyroid cartilage. And you can see how that's measured right there. And their cutoff was 5 centimeters. So if they had patients with more than 5 centimeters of thyromental height, they found that those airways were much easier technically to intubate than those patients who had less than 5 centimeters. That was the cutoff. The other thing I liked about this is that you can measure this without the patient moving his or her head or neck and without requiring some special protractor. In fact, you can see here in a couple of the pictures, there are basic trauma shears with some centimeter increments on them, and those are essentially used to measure the thyromental height. At the bottom, there's a piece of metal that's bent to 5 centimeters and is used in a similar fashion. What they found is that in the thyromental height test compared to other tests that are out there, it had a sensitivity of 77%, which is better than all the other tests that are available, and in specificity that's sort of in the same ballpark. So you have a test that's, none of these are perfect, of course, if you look at the sensitivity and specificity for any of these, but it has decent sensitivity and specificity as a single element assessment, which can be done quickly in a couple of seconds without the patient having to cooperate, which is really important in emergency department populations. So I thought this was an important study because it gave us a tool to use when the other things might fall apart. Lemon, for example, has a Mallampati assessment. That's the M in lemon. Mallampati requires the patient to open his or her mouth, stick out his or her tongue, and in a lot of our patients, we're intubating them with depressed GCS, or they're agitated, or they're trauma patients, and you can't do that with them. So I thought this was great because you can use medical equipment, you can use a bent piece of metal, it can be done quickly at the bedside in essentially 5 seconds, and it should be able to be applied to really any single patient unless they don't have a chin. Okay, and the last contender is this paper, which was in the Canadian Journal of Emergency Medicine earlier this year. We reviewed it either in March or June, I can't remember. It's entitled The Association of Rocuronium Dosing and First Attempt Intubation Success in Emergency Department Patients. This was a NEAR study that looked at stratified rocuronium dosing in 0.1 increments and the impact on first attempt success. So we stratified patients into, based on their estimated weight as recorded in the registry and the dose of rocuronium that they received, as either having less than 1 milligram per kilogram of rocuronium administered versus 1 to 1.1, and then we went up by 0.1 increments every single time, and we eventually got to a point where we had a high dose range of greater than or equal to 1.4 milligrams per kilo. And what we found is that in patients who were hypotensive, as you can see in the second set of results there, pre-intubation systolic blood pressure less than 100, and in patients who are intubated with a direct laryngoscope, that's in the bottom graph, blue line, we found that there was a significant improvement over the dosing range as you escalated weight-based doses of rocuronium. And this makes a lot of sense, right? If you have a patient who's hypotensive, drug delivery is dependent on adequate blood flow to the motor end plate, that you can compensate poor perfusion by administering more drugs, or at least more weight-based drug. And that makes a lot of sense for this finding right here, where the 95% confidence interval does not cross 1 as opposed to the other areas except for DL. And if you looked at DL compared with VL over the dosing range, you can see that there was a steady improvement in first attempt success from the low 80s to almost 90% when you used high-dose rock. The reason why this is, we assume, is because the intubating conditions are better. You're estimating weight in the emergency department. There's no downside to giving someone a little bit more of a non-depolarizing neuromuscular blocker. And if you happen to underestimate their weight and give them a light dose of rocuronium, then you can have slower onset or incomplete paralysis, and that's going to hamper attempts to see the glottic inlet with a direct laryngoscope. It had no impact on VL, as you can see with the red line. And that's likely because VL is less impacted by intubating conditions. Intubating conditions do not need to be perfect for VL to give you an adequate view. So that's why that finding kind of shook out the way it did. Now, what stemmed from this is what is going to be a new recommendation in the next edition of our Airway manual, which is that the intubating dose for rocuronium is going to be 1.5 milligrams per kilo as a global recommendation. Now, some of you I know are already doing that. We're going to make that recommendation, at least in part, based on some of the findings from this study, which is one of the reasons why I thought it was a good contender for Airway Article of the Year. Okay, now it's time to vote. Having presented with you, albeit quickly, the different studies, let's see what you all think. So is it the driver study, engagement of the median glossoepiglottic ligament? Is it peri-intubation cardiac arrest? Is it the assessment of thyromental distance as a difficult airway assessment, or the association of rock dosing and intubation success? Ooh, it's moving around quite a bit. I like this. And you all have spoken. Congratulations to Mike April and his writing group and the NEAR Collaborative for their Airway Article of the Year award for peri-intubation cardiac arrest in the emergency department. So congratulations. This is great. I thank you all for sticking around and listening to those contender presentations and voting. We will make sure that we let Dr. April know of this tremendous honor. And I want to thank you for joining us for the 10th Annual Airway Article of the Year Award Show. This concludes our presentation, and we will see you all in 2022.